All right, everyone. So we're doing the recording a little bit differently this time, where I'm just going to be showing you my screen and not me. So I'm going to be talking you through the intake report description and grading rubric. And this is, I'm focusing on the rough draft today, but really in talking about the rough draft, we have to talk about the final draft. So we'll be talking about both. So I expect this to be about 4 to 6 single-spaced pages. Single-spaced meaning not double-spaced. So this document is single-spaced, okay? So that's what single-spaced looks like. I do expect this will be about 4 to 6 single-spaced pages, and that's not including the appendix. So there will be an appendix with scores for the measures, and that is on top of those 4 to 6 pages. Times New Roman, 12-point font, 1-inch margin. So give yourself time to write this. This will take some time to, of course, do all the interviews that you've already done some of, but also to really write it up. The first draft is only worth 10 points. The final draft is worth 35 points. But keep in mind that it is in your best interest to do a really good job on that first draft so that you can get feedback that's going to be really relevant to you when you're creating your final draft. Your first draft is graded out of 10 points. It's really what I'm looking for is, did you actually do everything that is required for the final draft? Did you put all the sections in? Did you write something in each section? Did you write in proper grammar? If so, you're going to get 10 points. So the grading for the first draft is very easy. I'm also going to give you feedback using the final draft rubric, and I'll give you detailed feedback. I will take a lot of time to give you some really detailed feedback to represent what your grade would have been if this was your final draft. And also, in your final draft, your grade will reflect what work you did to put my suggestions from your rough draft into play so that you actually incorporate my revisions. If you incorporate my revisions well, you'll get a higher grade than if you ignore my revisions or if you don't really put my revisions into place. In terms of the purpose, the intake report is something that all therapists do at some point in their careers, and some of you are going to be doing them constantly. Hands-on real-world practice, providing you practice with a psychodiagnostic assessment of a simulated client, writing up that assessment in a detailed intake report. Now, at your agency, the format is likely going to vary. Intake reports might be required in the beginning. They might be required never. They might be required every 5 sessions. It really depends on the agency. And often they're required by insurance companies, progress reports, intake reports. So this is really a useful skill to learn. Another purpose of the assignment is to give you a chance to begin the process of creating therapy goals and interventions with your client. And for you to really experience how important assessment is, not just in diagnosing your client, but in providing them with effective intervention. So the assignment fulfills program learning objectives of learning counseling skills and problem-solving skills, preparing you to meet BBS requirements, and providing you with legal and ethical competence. In addition, it fulfills several of the course-specific objectives, comprehending various areas of assessment, demonstrating interview and intake skills, developing critical thinking skills, comprehending various content areas of psychological assessment, demonstrating competency of administration, and introducing you to writing and interpretation of assessment reports. So, in a lot of ways, this is a culmination of everything you're learning in this class. That's a take-home point from all of the objectives that are addressed in this assignment. So, this is a variation on a typical report done in a clinical setting like a community mental health center. It summarizes the patient's background, their current symptoms, provides a diagnosis, and discusses preliminary therapy goals. I want you to read through the sample assessment report. I will go over it quickly today. I will spend more time on this document, but we will also quickly go through the other document. But please do look carefully at both this document and the sample assessment report to get a clear sense of what I want you to write for each section. Feel free to use the same formatting and headings, but write in your own words. Do not use my same words. that is plagiarism. So write in your own words. I expect you to have a main heading of some kind. Say the client's name, the client's age, who they were referred by. If they came to you on their own, they were referred by self. That's what we say. That's what we say if they came on their own. But otherwise, we would say who referred them: a parent, a doctor, the court, etc. The day you interviewed the client. Now, you might have interviewed the client on several different days, so you might put each of those days that you interviewed them, and the case number. Just make up a case number, whatever you want to make up. The presenting problem. So that's in a couple of sentences, not a paragraph, okay? 1 or 2 sentences. Why is the client there and at therapy at your office? Then we go into the background information section. So there's quite a bit of subsections in this bigger section. There's background information, which is a large section of the paper, and then there's subsections underneath that. The first one is family mental health history. Any mental health problems in the family. So not in the client, but in the client's family. Now, generally, when we think of their family for this purpose, we think of their family of origin. That is their parents, grandparents, brothers and sisters, uncles, that kind of thing. People they are primarily genetically related to, or if they are adopted, we would also include that because sometimes people don't inherit something genetically, but are taught and modeled a behavior that then they take on. So whoever the client was raised by is usually what we're talking about here. If it's in the extended family, you don't necessarily have to say who. It depends. Sometimes clients have a request that you do not say who, since that might be shared with the family members. Other times you can be very specific. It's kind of up to you and the client to decide how specific you want to be about family members. And also if the client has if the client states that a family member has undiagnosed problems, that happens a lot. So the client might say, well, my mom had anxiety her whole life, but it was never diagnosed. Well, you would mention that here too. Mr. Smith reports his father had undiagnosed personality problems or anxiety or depression or whatever. So that would all be included there. Developmental history. So this is usually brief unless we have concerns about the person's development. Also, if it's an adult and we don't have access to their parents, this might be a vague section because they don't know what their developmental history was. But it's more relevant for children or for people who do have developmental problems. Generally, though, this is a pretty brief section that says something along the lines of no developmental problems were reported during gestation or early childhood. You would say if they were exposed to any toxins, for example, if they know that their mother who carried them in her womb smoked and drank during pregnancy, we would mention that here. Or if we know that they had a speech delay or a physical delay or anything like that, we would put that in this section. Okay, next section, social and family history and current functioning. So social history, meaning usually peers and romantic partners, and family history, meaning relationships with their family. So not the family mental health history, but their relationship history with their friends, romantic partners, and family of origin primarily, as well as their current family. So if they have a spouse and children, or if they have a current boyfriend, whoever their current family is, we would also mention that here. I have a little bit of information about what to include. What was their childhood like? Did they have any abuse or trauma? What was their relationship like with their parents, their siblings, their childhood peers? What about their current family? Do they get along? Do they have conflicts? Do they get along with adult friends? That's their social history. Educational history. So what's their highest level of education? What was their behavior like in grade school and high school? And this can be, again, we're really trying to be succinct in these sections. So something along the lines of behavior was reported as normal for her age in high school would be okay for excuse me, excuse me, would be okay for talking about these years. But now, if they did not have normal behavior and if they were involved in fighting or suspensions or anything like that, then this is where you'd talk about that. What were their grades like? If their grades were average, maybe that's all you'll say. But what if maybe they got straight A's or maybe they failed out of school? You would include things like this in the educational history. Medical and psychiatric history. So first, I like to break this up in two sections. First, a brief description of their physical health growing up and currently. So major childhood illnesses, things like polio or childhood cancer or pneumonia that made them miss 6 weeks of school, those kinds of, or a major head injury, those kinds of serious childhood illnesses might be mentioned here, and any current major illnesses, cancer in their current life, diabetes, asthma that is not well controlled, although you would probably mention asthma period, although you might specify whether it's mild or moderate or severe, any kinds of medical issues they're currently dealing with, obesity, that kind of thing. For the psychiatric history, you're not going to go into excessive detail here. You're going to go into more detail later. However, if they have a history of problems, which they probably do, that they are currently coming to your office with, you will mention that briefly here. Any psychiatric or psychological issues in their childhood, okay, particularly if they had their current symptoms at that age. If they were ever diagnosed with a psychological disorder, you would name that, state who diagnosed them, give their approximate date of diagnosis, mention if they were ever hospitalized for a psychiatric reason, and if they have any history of suicidality or homicidality. Again, we're focusing on brevity, so saying this pretty short, because you are going to go into more detail later. Medication history, for many people this will be very short. If they're not currently taking any medication, just say that. If they are, you would say what they're taking, and as much information as you can about their dosages and how frequently they take it. Also note if they took any meds in the past and what those were. Treatment history, so this is psychological treatment history. This is where you discuss past treatments the client has received, not only whether they were in treatment before, but what kind of treatment, how long they were in treatment, whether or not they felt it was useful. But again, this is not a very long section. This is just 1 to 3 sentences. Okay, legal history. So usually clients don't have a big legal history, so this might be very quick. No legal issues were reported. For other clients, they might have a history of arrests or charges against them, jail time, many tickets, many traffic tickets. Then maybe you would report those things. Substance use history. If the client has normal use of substances, we'll make this pretty quick. You mentioned the usage briefly, but only to demonstrate this is not a concern. So mentioning that they drink 1 to 2 drinks per week, for example. But if the client has past or current history of more problematic substance use, you're going to be more specific. Now remember that your client should not currently have a substance use problem. They might use substances, but they shouldn't have problematic substance use, because that is a diagnosable condition, and they're only supposed to have one diagnosable condition. So keep that in mind when you're portraying your client self, that they should not have problematic substance use. That said, many people use substances of various kinds in more recreational and non-problematic ways, and that would be mentioned here. Occupational employment history. So what are the different jobs they've had? If they've had, let's say, 6 jobs in retail, you don't need to mention the details about all 6. You would maybe just say they've had primarily retail related jobs for the past 6 years, for example. How has their job performance been? Have there ever been any complaints from their boss? Have they been written up? Have they been fired? Have they had commendations and rewards? That's all stuff that you would mention here. And then their mental status exam. This is the write-up of what you performed. So you did the mental status exam. And this is now your summary of what you learned. Look at my sample for some information about how to do this and what to include. But again, remember, you're trying to be concise. So it will be a longer section than some of the other sections have been, because you did gather quite a bit of information, but you're not going to be, for example, providing their answer to every question you asked, right? You're trying to summarize concisely what information you learned. And the more normal they seemed, the less you'll write, because they seemed like they're performing in an average way. However, if they say unusual things, then that is something you're going to say more about. Okay, so that's the end of the history section. Now we're going to talk about the results section. So that is where you list or describe the results from this intake that you did. So which tests were administered? You're going to list each of the questionnaires. Use the sample as a model. You did administer 4 questionnaires: the Beck Anxiety Inventory, the Beck Depression Inventory, the Mood Disorder Questionnaire, and the Brief Symptom Inventory. So you will list each of those. The results of psychological tests. You will also list clinical interview as one of the tests you administered, because although that's not a test in the way we think about some of these other things, it is a method of assessment and evaluation. So clinical interview is also included in that list. Then you talk about the results. So how I like to do this is in 2 paragraphs. So the first paragraph is going to describe the results of the questionnaires. You're going to focus in particular on results that indicate clinical impairment. You don't need to describe areas that were not clinically significant. So clinically significant means below the clinical threshold. In most questionnaires, that might be a T-score under 65, or however that questionnaire is scored, something that's below the cutoff for clinical significance. You don't need to say hardly anything about that. You can say something along the lines of their test scores showed that they did not have clinically significant symptoms. Be succinct but do highlight results that support the client's diagnosis or their statements during the interview. So I gave you an example. If the client mentioned issues with depression and her scores indicate she has depression, mention that and state how it is consistent with her stated symptoms. You're going to give specific examples of test items that the client endorsed which matched her symptoms well. And so, for example, if she said that motivation was a major symptom and endorsed the "I can't get motivated" item of the questionnaire, this is something you would talk about. If there are inconsistencies, and sometimes there are, so maybe the client stated he was anxious, but the test results do not show clinical significant anxiety, mention that inconsistency. Also give some rationale or ideas for why this inconsistency may have occurred. So maybe, for example, if the client mentioned severe worries during the interview, but then the BAI results are minimal, state how the BAI mostly relates to panic and somatic symptoms. Maybe the client's worries were less related to those areas, and that's why the BAI did not match up with what the client was saying. That's the first paragraph. Second paragraph is really going into detail about the clinical interview. What did the client say that were their symptoms, and how do those symptoms support your diagnosis? So always be thinking in your mind, I'm justifying my diagnosis. So the examples that I give are examples that support my diagnosis. You don't need to talk about everything this client said. You only need to talk about the symptoms that support your diagnosis. Provide good detail. Have the DSM in front of you, the DSM criteria. Make sure that you are providing all of the required criteria to meet that diagnosis. You're going to put the diagnosis later, but this is where you talk about the symptoms for it. Look at the DSM criteria. This is what I just said. Make sure you have them in front of you and use them when you're describing it. Make sure to mention when the symptoms began, their general course over time, how they impair the client. Don't mention things that aren't an issue. So if they're depressed but not anxious, just talk about how they're depressed. Okay, So the next section, case conceptualization. Summarize the client's statements regarding their current symptoms, when those symptoms began, how they impair their life. Should be just a brief summary, because the idea with the case conceptualization is it's the last section of the report before the diagnosis, and sometimes it's the only thing that the other providers you're working with may read. So we are going to give a very quick summary of everything you said before, but really just a few sentences. The next paragraph is your hypothesis about how these symptoms developed. Probably going to be influenced by your theoretical orientation. Your theoretical orientation could be anything right now. You might not know what it is, but assume a cognitive behavioral theoretical orientation if you feel like you have no idea what you want to come from. So from a cognitive behavioral theoretical orientation or therapeutic orientation, we are asking, what are the thoughts that are irrational or unhelpful that are perpetuating these emotions? And in what way are maladaptive behaviors being reinforced by the environment? Okay, in the next paragraph, you're going to give a general description of your therapy plan. This should be brief, enough to give a snapshot of the plan. This section is often influenced, again, by your therapeutic orientation, and you can come from the cognitive behavioral orientation if you don't know where you're coming from. If you say, I'm just at the beginning, I don't know, that's fine. Just choose cognitive behavioral as your orientation. And again, the intervention then would be on revising your irrational cognitions and reinforcing appropriate behaviors instead of maladaptive ones. There's not really a right or wrong answer here. It's more about you showing your thinking, that you've looked for evidence, that you've considered your client's symptoms, you've created a plan that seems to address their problems. Finally, in the last paragraph, take a few sentences to talk about their strengths. Be as genuine as possible. Don't say they're intelligent if they're not. Don't say they're friendly if they're rude. But find something positive to say about them. Make a general statement about how motivated they seem to be in therapy. Again, be genuine. If they seem completely unmotivated, don't say that they are, okay? But if they seem motivated, you can mention that. And then state confidence if you feel like you have confidence in the client's willingness and motivation to change. And how accurate of an assessment this seems to have been. And that's something else to say here. And when you are doing these intake reports, the idea is that you feel like you've gotten a good picture of this client. So that's something you also say. Okay, for diagnosis, you are just going to give the diagnosis. You do not need to say anything else about the diagnosis. You just need to list the diagnosis along with the number associated with the diagnosis in the DSM. So the DSM, and right now we're in 5TR, the DSM-5TR has a specific number, a code associated with each diagnosis, and particular specifiers that go along with the diagnosis. For example, major depression, you have to state whether they're currently in remission, the severity of their diagnosis, and whether this is a current or recurrent episode. I can't remember exactly, actually. I might be getting one of those wrong. But there are specific specifiers that you have to state along with the diagnosis. So make sure you're providing the appropriate specifiers. Also, state significant psychosocial and contextual features. I like to list those in a little numbered list. You could also put them as V codes, and there are V codes in the DSM-5, but you could also just list them, like distress in marital relationship, or academic, poor academic performance. So this is, these are your very quick one or two word summaries of their additional stresses on top of their diagnosis. Sometimes people get confused by this and they state things that are symptoms of the diagnosis. So stressors are not symptoms of the diagnosis. The diagnosis is a stressor, yes, But on top of the diagnosis, what are other stressors that the client is currently experiencing? So, for example, let's say the client has generalized anxiety disorder. A stressor would not be persistent worrying. No, that's a symptom of generalized anxiety disorder. Instead, a stressor would be something like recent loss of home, right? If they have recently become homeless, or recent cancer diagnosis, if they were diagnosed with cancer, right? Or arguments with spouse, right? So these are all associated or just also ongoing for the client, but they are not symptoms of anxiety. They are on top of that diagnosis. Hopefully that makes sense. For therapy goals, you're going to state 3 to 5 goals of therapy. It could be more, could be less, but probably not less. You're probably going to you're going to find yourself making more than 5 goals for therapy. But I encourage you to stick to roughly, not more than 6 or 7. They're ideally crafted with the client. You are going to go over these goals with your client in the feedback interview and may make some changes as a result. But for the sake of this assignment, you don't have to talk about them with the client first. You're just going to do a draft first before you talk about it with the client. Really be thinking about why the client came to therapy, what's their presenting problem, and what does better look like to them when you're making your goals. In a real intake report, you'd have a more specific therapy goals, like after 3 months of therapy, client will no longer have crying spells. They can be more general, but do your best to make them real, to make them feel like they're real goals that this client would have. In planned interventions, state in this section how you plan to achieve each of the therapy goals you just stated. You might have up to 8 or even more bullet points, but make sure all of the therapy goals are addressed. And really make sure you're doing this in as comprehensive a way as possible. Then there should be signature lines where you talk about how you've enjoyed working with your client, you look forward to working together, have a signature line for yourself and for me. You do not have to sign it. There's also at the very end of your paper an appendix where you list the questionnaires you completed and the client scores. They've completed 4 questionnaires, the BDI, the BAI, the BSI, and the MDQ. Make sure you include all of them. There's in the sample paper, there's a format for how to report these. And just make sure that you're following all these recommendations that I have here. And finally, I have the rubric for how I'm going to be grading you on your content, your organization, your coherence, your mechanics, vocabulary and style, and finally, how well you incorporate revisions that I provide for you. Okay, so we're going to very quickly go through a sample report. Let's do it this way. Oh, and I don't have it up here, so hold on. Give me a minute. I'm going to find it. All right, I'm going to have to show you in a different video. All right, so here is the sample, and I obviously have, this is an older sample, so the dates are old, but you would update them. But here's the heading I was talking about. Excuse me, then this is the name of the client, the age of the client, who they were referred by, the examiner, which is you, supervisor, which is me, the dates of the evaluation and the case number. A presenting problem, as you can see, it's very short. Background information, family mental health history, developmental history, family and social history and current functioning, educational history, medical and psychiatric history and current functioning, medication history, treatment history, legal history, substance use history, occupational history. Then we move to the mental status exam, and you can use this same format to write your own, although please use your own words. Results, so this is the tests that were administered. This is the results of the psychological testing. First, I have the paragraph about the questionnaires. Second, I have the paragraph about the clinical interview. Then case conceptualization. This is my brief summary of the client and why she came. This is my consideration of why I think her symptoms have started. This is her the treatment approach I believe will be effective. These are her strengths that I feel will be to her benefit. Then here's her diagnosis. There's the DSM code, and I have given her a diagnosis of adjustment disorder with anxious mood. Of course, this is not one of the ones that you have on your list, so keep that in mind. Only I diagnose one of the diagnoses that's on your list. Make sure to include any relevant specifiers. I also have the psychosocial stressors here. For her, it's intense academic workload, financial strain, and concern about unknown future career prospects. Then I also have a list of therapy goals. For her, it's a rather short list, but I am specific in how they are going to be measured. Then I have a list of planned interventions. Each of these interventions is designed to address the goals above. Then I say I enjoyed working with her, and I have signature for you and the supervisor. Finally, the appendix. And you can use the exact same format for the appendix. Just make sure that you are changing the scores, obviously, to be relevant for your client. And I have a little makeup of all of those, okay? So hopefully that's helpful for you, and let me know what questions you have.